We analyzed about 100 patients who underwent allogenic bone marrow transplantation for acute myeloid leukemia in our center, and we selected the patients who were allocated for stem cell transplantation in an advanced phase of disease, that it means beyond the CR2. And we evaluated if MRD could be a strong predictor of relapse and survival probability. And we confronted MRD with classical leukemia and patient-associated variables such as the European Leukemia Net risk assessment, patient age, conditioning, and so on. MRD was evaluated by two of the most feasible methods that are multicolor flow cytometry, which is feasible in about 19% of AML patients, and WT1 gene expression level, which is feasible in about 70% of patients. And we used the two methods because we tried to cover all patients with one or the other methods. We were able to perform MRD in all 100 patients, and we found that MRD status abrogated any of the other risk factors. That is, patients with a favorable risk leukemia who were MRD positive had a higher risk of relapse comparable to higher risk patients, whereas patients with higher risk leukemia but MRD negative status at transplantation had a very low risk of relapse if compared to the setting when this transplant was performed. Thus, MRD had a stronger value than more classical variables such as age, risk, and transplantation conditioning intensity. And we think that MRD should be implemented in the risk assessment phase before transplantation in order to take some decision on whatever perform a reduced intensity or full intensity conditioning in some patient with borderline age, or to perform some post-transplant intervention in order to reduce the risk of relapse in MRD positive patients, such as donor lymphocyte infusion or hypomethylating agents and so on.